Hi everyone, welcome to Radhakrishna Health Channel. Let's learn about ovarian rejuvenation today. Why do we need this? We need this because as age advances, the ovarian reserve starts falling. And when it starts falling, the chances of conception comes down. That is why today we are talking about oocyte cryopreservation and ovarian tissue cryopreservation. But if the damage has already happened, then what do? We have to think about ovarian rejuvenation. Now, let's know a little about the ovarian function, the egg quantity, quality, and ovarian reserve. Now, this is basically because when a woman comes to us, we should know where she falls in the WHO classification and how much of egg reserve she has and what kind of egg quality you're going to get or the number of oocytes you're going to get. When we talk about the ovarian reserve, it is chronological age versus the biological age. Loss of oocytes is a continuous process. Aging oocytes have been widely suggested to be the major cause for infertility. Now let's look at what happens in a woman's life. At fetal life, it is 6 to 7 million oocytes. At birth, it comes down to 1 to 2 million oocytes. At menarche, it is around 3 lakhs ovarian follicles, and at menopause, it is 1,000 ovarian follicles. So when the ovarian reserve falls, we do not have 3 lakhs ovarian follicles. It comes down to in thousands, and we will have to encash on these 1,000 or 2,000 or 10,000 follicles, whatever we get once the ovarian reserve comes down. So the primary causes of reproductive aging and the molecular factors responsible for decreased oocyte, the quality and quantity remains elusive. Aging of the female germline is accompanied by mitochondrial dysfunction associated with decreased oxidative phosphorylation and reduced ATP level. So the ASRM has different definition. The Poseidon criteria is different. The Bologna criteria is different. Let's see the ASRM definitions for poor ovarian reserve. The ovarian reserve and diminished ovarian reserve. The normal ovarian reserve may be defined as the number and quality of the remaining follicles and the oocytes in the ovaries at a given age. The diminished ovarian reserve is loss of normal reproduction potential in the ovaries due to a lower count or quality of the remaining eggs. We have the references below. You can just have a look at it. Now, the ISHRE definition of poor ovarian reserve is identified by a reduction in follicular response to maximal stimulation during the IVF procedure. Now, the poor ovarian response definition as per the Bologna criteria. Advanced maternal age more than 40 years or any other risk factors for poor ovarian reserve. Previous IVF cycle or oocytes with conventional stimulation is equal to 3 or less than that. An abnormal ovarian reserve test, that is less than 5 to 7 follicles, or AMH less than 0.5 to 1.1. The normal AMH levels is between 2 to 5. If it is above 5, then we call hyperstimulation. And if it is below 2 and 1, between 2 and 1, it is decreased ovarian reserve, and below 1, we call it poor ovarian reserve. So what is this Poseidon classification? Female reproductive system undergoes a variety of changes over time due to aging, pregnancy, and other factors. These changes can result in reduced fertility and other complications. You have the group 1, 2, 3, and 4. Now, this is basically based on the cycles, that is the age. Second is the ovarian biomarkers, AMH or AFCs. And third, number of oocytes retrieved in the previous ovarian cycle. Now, young lady, less than 35 years, then AFC around 5, AMH 1.2, this subgroup 1A and 1B, and this group 3 is again, these two are better. These two have at least better ovarian reserve, that is less than 35, less than 5 follicles, and less than 1.2 AMH. And the other extreme criteria or group 2 is advanced age, AFC equal to 5, and AMH about 1.2. And the group 4 is AFC less than 5, 35 years and more, and AMH less than 1.2. So the group 2 and 4 have aneuploidies, and group 1 and 2 aneuploidy risk is low and pregnancy outcomes are better, whereas group 2 and 4 have high risk of aneuploidies and miscarriages. So according to this Poseidon patients, low embryo aneuploidy risk is group 1 and 3, and 2 and 4 high embryo aneuploidy risk. So few embryos generated, reduced cumulative live birth rate. So poor ovarian response is the key indicator for diminished ovarian response. So ovarian response is defined as actual oocyte yield after ovarian stimulation. It is classified based on oocytes retrieved or retrieval at OPU. When you say it is poor, it is less than 4 oocytes at OPU. And when you say excess, it is more than 14 oocytes, that is hyper-responders or PCOS, and with a number of increasing immature follicles. So those are PCOS patients, and that's how you differentiate between the two. Now, what are the causes for low ovarian reserve? Radiotherapy, pelvic infection, mumps disease, endometriosis, and smoking. More than mumps and radiotherapy, it is pelvic infection. Even the more complicated or even the more grave is endometriosis. So in endometriosis, because of the damage caused to the ovaries, the ovarian reserve falls down. So there could be either no or few follicles, or even if the follicles are present, they are not healthy because there is dysfunction of the follicles. Okay. So the different tests for ovarian reserve, most recent markers for ovarian reserve is that is serum AMH and ultrasound antral follicle, and they have shown to have a direct response to the ovarian reserve testing. And AFC and AMH are highly correlated, and they give you even the quality and quantity of the oocytes also. Comparing AMH and AFC has the advantage of very little inter and intracycle variability, and also the ovarian volume. When you do a transvaginal scan and you see that the ovarian volume is down, then there are chances of that you can think that it is diminished ovarian reserve. So ovarian reserve tests, what are you doing? Age, menstrual cycle characteristics, and AFC, that is ovarian volume and ovarian blood flow. And then you have basal FSH, basal E2, AMH, and inhibin B. And of course, if you want to test the Clomiphene challenge test, then you have the exogenous FSH test, and then also the gonadotrophin stimulation tests. So these are dynamic tests. Biochemical is AMH and inhibin B. Clinical, of course, we know about the menstrual history. And on ultrasound, we know the AFC, ovarian volume, and the vascularity. The combination of biochemical tests are effective in decreased ovarian reserve. That is, you do AMH, you do AFC, and the FSH also, and inhibin B. That is, you combine all the three and then you come to a conclusion. Only AFC and AMH is enough because the other two tests may work out expensive to the patient. So you can just do with these two tests. Adjuvants in poor ovarian reserve, what you can give. So what all you can give for a woman with decreased ovarian reserve, that is growth hormone, pyridostigmine, then coenzyme Q, testosterone, DHEAS, letrozole, and estrogen and OC pills. The growth hormone Of course, in our center also, we have a publication on this. The mode of action is it enhances the ovarian response to FSH and thereby stimulates the ovarian steroidogenesis and follicular development. Growth hormone and its intermediary insulin-like growth factor promotion and proliferation of granulosa cells, which in turn is critical to the nourishment and health of the oocyte. So both insulin-like growth factor 1 and IGF-2 are present in the follicular fluid and are believed to play a crucial role in cytoplasmic maturation and in potentiating actions of FSH. The dosage and timing is 8 to 12 milligrams per day. It comes in 4 milligram injection to be started along with gonadotrophins till we get the trigger. So what happens here when you give this? There is increased androgen, increased proliferation, and increased gap junction. So in turn, the LH, FSH receptors increase, and then cyclic AMP, and then proliferation and steroidogenesis of the granulosa cells takes place. So the adjuvant growth hormone, what do you give when you give adjuvant growth hormone? Despite the possible beneficial effects in poor responder on the live birth rate, the evidence is too limited to give or recommend growth hormone because it works out expensive for the patient in a cycle. So studies are very small and definition of poor response is heterogeneous, and poor ovarian reserve, poor response to gonadotrophins, less number of embryos. So we have not got maybe 1 or 2 more. So the GH dosing schemes were, again, it was a little heterogeneous, 1 to 12 units. There is no streamlined or structured dose which is being given. So, and there was a paper saying that they do not recommend for poor responders because they did not get any results. But this is our own paper, and when we gave growth hormone 4 milligrams daily from the day 2 of cycles up to the trigger, the number of oocytes are retrieved and the pregnancy rate in poor responders were better. So this is another paper on growth hormone, beneficial effects, the probability of clinical pregnancy and live birth rates are better in IVF cycles. Then this drug, pyridostigmine, it is an acetylcholinesterase inhibitor, which enhances the action of acetylcholine, which inhibits the somatostatin release in brain and thereby increases the growth hormone secretion. See, whatever you're giving, it has to basically increase the LH and FSH receptors and also stimulate the growth hormone secretion. And then maybe you will get good quality oocytes and that will benefit oogenesis. So growth hormone can then have a beneficial effect on oogenesis. This was a study which was conducted, but they did not find any classical difference. So the recommended dose was 60 milligrams twice daily from first day of stimulation till the trigger. The coenzyme Q, this I think we are giving right and left. Diminished expression of the enzyme responsible for CoQ production, that is PDSS2, and then the CoQ6 was observed in oocytes of older females. So the age-related decline in the oocyte quality and quantity could be reversed by the administration of CoQ. So reduced form can act on an antioxidant-rich resources of dietary coenzyme Q include mainly meat and poultry and fish. So what happens here? What exactly happens? Post-ovulatory aging, so there is decrease in superoxidase, decrease in, post-ovulatory aging, you have increase in superoxidase and increase in apoptosis. So when you give coenzyme Q, the superoxidase decreases, apoptosis decreases, the oocyte quality is better, and the cytoskeleton assembly, organelle arrangement, and fertilization capacity is better. So women with coenzyme Q, they had better oocyte retrieved and better number of oocytes retrieved, and then the fertilization rates were better. Significantly fewer women treated with the coenzyme Q had cancellation of the cycles, And significantly more women from this treatment where they had embryos for cryopreservation also. That means the number of eggs retrieved were more, the embryos got were good, and after transferring the embryos, they had embryos for cryopreservation, giving them a chance in the next cycle to conceive. And the clinical pregnancy and live birth rates per embryo transfer and per complete stimulation cycle tended to be higher than when you compared with the normal group. So you can see the statistics here that fertilization rate was better, cancellation was less, and available embryos were more. So this is again a study on coenzyme Q, which says that they significantly improved the pregnancy live birth rates and the quality of the oocytes. Then letrozole. Now letrozole, we know that now we have been giving letrozole for ovarian induction, ovulation induction. But previously, when we thought of giving letrozole, it was not accepted and it was banned for some time. But now we have started giving. A mechanism of action has been proposed for low responders, whereby the intra-ovarian androgen concentrations are increased by inhibition of aromatization, leading to a potentiation of follicular response, similar to the proposed mechanism whereby the androgens are administered to increase the ovarian response. So this paper, which came in 2017, they said no, there is this is the 2017 article. They said no, there is no good with letrozole, so we will have to not give letrozole. So then there was another paper which came in 2019. So they said when minimal stimulation was given with letrozole, it produced a reasonably live birth rate and poor responders and potentially higher quality oocytes than conventional IVF protocols. So then in 2021, they said, no, it is very good. It is good for poor responders. A meta-analysis was given. And then they said that in a multicentric place, when they gave the letrozole, the amount of GnRH also was less and the oocyte quality was better. So the meta-analysis for poor ovarian reserve showed an increased cumulative pregnancy rate, fewer days of stimulation, and reduced total FSH consumption with letrozole co-treatment during ovarian stimulation. So the key message is, in our center, we do give a lot of letrozole for poor responders. We give 5 mg a step-up dose. That is, first day it is 5 mg, second day it is twice 5 mg, third day it is 3 times, fourth day it is 4 times 5 mg, and 5 days, last day it is 5 times 5 mg. So co-treatment during stimulation for IVF and intracytoplasmic sperm injection may benefit poor responders by increased live birth rate. So currently evidence is insufficient to support this recommendation, but I think you need more studies for this. So the ASRM guidelines, the American Society of Reproductive Medicine states that in women considered to be poor responders, there is a fair evidence that the clinical pregnancy rates after IVF are not substantially different when comparing with mild stimulation using combination of oral agents and low-dose gonadotrophins. So there is no data about the live birth rates. So testosterone. This is another gel which is given now, the testosterone gel, that is androstenedione, and the DHT can promote early follicular growth and enhance FSH. The mode of action is testosterone increases both the antral follicles and the number of granulosa cells. So the androgens act directly via the androgen receptors, and the androgen receptor messenger RNA correlates positively with the granulosa cells proliferation and negatively on the granulosa cell apoptosis. So androgens also have a indirect effect by their conversion to estrogens 3-beta-diol that can activate the estrogen receptors. So the testosterone has been shown to cause a marked increase in the ovarian response in women who had consistently poor response to a repeated IVF stimulation. So DHEA, what happens with DHEA? DHEA supplementation, it increases androgen, increases the rescue atresia, increases the follicular growth and decreases apoptosis, increases FSH receptors, increases ovarian response, increase IGF, the growth factor, insulin-like growth factor 1 and 2, and also IGF-BP3. So increase oocytes and embryo quality, and of course the increase in the oocyte yield. So when you start giving DHEA, it is given 25 mg for 4 months on an average TID for almost 3 to 4 months it is given. And this study of Weiser et al., they said that patients with diminished ovarian reserve, DHA supplementation, although the study was criticized for severe methodological and statistical problem, but they did show that they had better pregnancy rates. However, 2 meta-analysis said that there is no response at all. So then estrogen progesterone combination pills also can be given as a pre-treatment in IVF cycles, which we do in our centers. And this, of course, helps, the same thing, estrogen and progesterone receptors increase, and then it helps in better follicular growth and the number of oocytes. So the adjuvant therapies, androgens, growth hormone, and aspirin, nothing has sufficient data, but we have something to offer to our patients. These are the different guidelines. You'll get it in the net. But let me talk about the newer approaches. So the newer approach for parenthood, that is rejuvenation. That is what we call the uterine and ovarian rejuvenation. So in this, what we have to see is that it refers to restoring the ovarian function in a woman who has diminished ovarian reserve or premature ovarian failure. One of the promising technique is ovarian tissue cryopreservation. But what else can we do? So what else we are doing is we are trying to give PRP injection to the ovaries. And this also, what is the composition of PRP? PRP has fibroblast growth factor, that is tissue repair and cell growth, collagen production, then platelet-derived growth factor, that is cell growth and new generation and repair of blood vessels and collagen production, VGEF, that is vascular endothelial growth factor, that is growth of new generation of vascular endothelial cells, transforming growth factor beta, that is growth of endothelial cells and endothelial cells promotion of wound healing, and keratinocyte growth factor, that is growth and new generation of keratinocytes. And lastly, the promotion of epithelial cell growth, that is angiogenesis, promotion of wound healing. All those things can be done with that. So blood is collected, a small amount of blood is taken from the arm, and then the PRP is separated. There are PRP kits available. So PRP is separated by centrifugation, and then the activation of platelets, that is platelets are activated with Ca1++, and it is injected either through laparoscopy to the ovaries or transvaginal ultrasound. What is the stem cell therapy? This is regenerative medicine and biomaterial approaches to treat injured uterus and the ovaries. So direct injection of bone marrow derived stem cells, that is you take from the iliac bone and then you do the centrifuge, and then you process it and then you inject. So the fabricated synthetic are yet to come, and engineering of nanoparticles are yet to be done. So the tissue growth differentiate into resident endometrial stem cells. So this stimulation of dormant endometrial stem cell and progenetic cells even into the active cell form. So this is how you do it. From the iliac bone, the needle is put into the iliac bone, and the stem cells are taken, and then this is taken to in the centrifuge in different test tubes, and then there is a kit for this, so that kit is used. And then once you centrifuge it, what you do is you get a different color as compared to the PRP. The PRP is slightly light, and the stem cell is slightly more amber color. So what you do is you identify both the ovaries, take an ovum pickup needle and inject about 3 to 5 cc of the stem cells into the ovaries. And 2 to 3 months later, you can stimulate, and then you'll get a better quality oocytes and better oocyte yield. So this has to be done in both the ovaries. No coagulation if it bleeds. Just gently hold it And home pickup needle is very good. That is because it is very thin, less traumatic, and you can easily inject into the ovaries and the endometrium. Are injected into the endometrium. And when we have injected subendometrial PRP, we too have got good results. Then, of course, the other one is ovarian tissue cryopreservation. This also, ovarian tissue strips are taken, it is cryopreserved, and then a tunnel is made, and this strip is once again sutured on the ovaries. But the only thing is, before you do cryopreservation, stimulate the patient and you retrieve the eggs. That is, oocyte cryopreservation has to be done, because you never know what will happen. So fertility preservation, self-fertility preservation, I always tell my residents, if you're postponing pregnancy, please do oocyte cryopreservation. So gamete cryopreservation can be done if they know who's the partner. Otherwise, oocyte cryopreservation. These are different recommendations. This is pool IVF stimulation. We do a normal pooling, then minimal drugs with letrozole. We do different protocols of stimulation. No single protocol is 100%. Whichever is good, you can follow that. This is our journey in pooled IVF cycle, that we have had 17 patients with AMH less than 0.5 and underwent pooled IVF. And pooled IVF is done in poor ovarian reserve with minimal stimulation, that is letrozole, for 3 cycles. And we've got about minimum 6 embryos, 6 to 8 embryos, with all grade 1 embryos we have got. And then we have transferred, and this is our pregnancy rate. So it is still in press. We will publish it soon. So as I told you, no ideal protocol. You can do agonist, antagonist, microflare, letrozole with recombinant FSH and LH, depending upon the Poseidon group. This is again different protocols which is described for by Ishray and Poseidon. But to conclude, ovarian rejuvenation has to be considered in women with poor ovarian responders, depending upon the Poseidon criteria. With new ART bill, seeking third-party reproduction is a challenge. So we should think about pooled IVF and should be considered as and when required. And stem cell therapy shows probably promising results in future for parents who are seeking parenthood. Everybody would want their progeny. So I think we should encourage and help them so that they also get an opportunity to become parents. Thank you very much for your kind attention.